Hello, my dear students. A very good evening to one and all. I am Dr. Anaya Kulkarni Kale, your faculty for Pedodontics with DBMCI. And today I'm here to solve your Pedodontics part of the INICET exam. I hope overall your performance was up to the mark, like how you've expected of yourself. And when I talk about pedodontics, as I just went through all the questions that appeared in the INICET paper, I could find that only a couple of them were a little tricky questions. The rest of them were really straight, easy to understand, and I hope you've attempted it correctly. So now that before I begin with the solution of the papers, let me just mention it to you that you are really fortunate to be associated with DBMCI, as DBMCI is the first and the only institute that has procured all the questions of the INICET and are analyzing and solving the questions. So let us begin with the first question. The first question that came for the pedodontics was, and this one, it is a direct picture question, and the picture shows a primary dentition mouth that has a brownish discoloration in the anterior region. Okay, so the question is, what is happening to the child shown in the image below? This child has just had one visit to the children's dental faculty, dental facility. Okay, there is somebody messaging. Yeah. So this child has just had one visit. So when as soon as they say just had one visit to the children's dental facility, that means a primary treatment has been done. So when you look at this picture, this is definitely not dental caries, okay, because a gross destruction of this level would leave only root stumps in the mouth, and this is not dental caries. It looks like a sort of a discoloration. It is not fluorosis, definitely. Why? Because a less severe grade or a moderate grade of fluorosis leaves a yellowish discoloration on the teeth, and a very high grade or severe grade of fluorosis will have dark brown pigmentation with pitting. Okay, so fluorosis of severe grade that actually has such a brown pigmentation as shown in the picture is accompanied with pitting. That means there are small pits that are present on the teeth. So definitely it is not fluorosis, because, and also the rest of the teeth seem to be okay. There is no problem with the rest of the teeth. So it is not fluorosis. It is not sodium fluoride application as well, because sodium fluoride is not known to cause any discoloration of the teeth. So definitely the answer here is SDF application. So why do we apply SDF? We apply SDF because it is known that the silver diamine fluoride, that is SDF. So what is SDF? SDF is silver diamine fluoride. Okay, so this is a form of fluoride that can arrest the active carious lesion also. Like for example, if you remember from our class, we had read about infected and affected dentine. So a part of the infected dentine that has an active microbial activity going there, the effect of silver diamine fluoride can actually stop an active microbial activity and arrest active caries also. So a patient like this, like when you see this picture, you can make out that this might be of a very young child, say, you know, for example, 3 years, 2 years, something like that, because all are primary dentition. So a child this young will not be cooperative. So in order to just arrest the carious lesion in whatever stage they are, because the child might not be cooperating enough for a restorative treatment, the dentist would have just painted SDF on the teeth. Now, why SDF exactly? Because the one and only disadvantage of silver diamine fluoride is that it leaves the tooth surface blackened. It gives a blackish discoloration to the teeth. So where it has an advantage of arresting the active carious lesion, it has a major disadvantage of making the teeth black in color. So let us just view very quickly what does silver diamine fluoride exactly do. So silver diamine fluoride does three things. The first thing that it does is it gives out silver particles because it has silver in it. So it will give out silver particles, and what do those silver particles do? These silver particles occlude the dentinal tubules. These silver particles occlude the dentinal tubules, and this part actually is where silver acts as a anti-sensitivity agent. That means it masks the hypersensitivity. Even in adults, there are toothpaste, there are formulations now that have silver in it because silver occludes the dentinal tubules and it causes reduction in dentinal hypersensitivity. So the silver particles help in reducing the sensitivity. This is one function of silver diamine fluoride, reduces sensitivity. The second thing, what it does is the calcium fluoride and insoluble calcium phosphate is released. So when calcium fluoride and insoluble calcium phosphate is released, it gets combined with the hydroxyapatite crystals and it forms something called as fluorapatite. Fluorapatite, that means a hydroxyapatite crystal has just given off the hydroxyl group and has accepted a fluoride group, making a crystal called as fluorapatite crystal. So this fluorapatite crystal will act as a reservoir one. That means it will give a sustained release of fluoride, which is an anti-carious agent. So it will act as a reservoir, just giving out a sustained release of fluoride. And second, it will cause resistance to demineralization, of course, because it is acting as a reservoir of fluoride. So two things we've read. The silver particles of SDF will help in occluding dentinal tubules, which will reduce the hypersensitivity, and the calcium fluoride and insoluble calcium phosphate shall form fluorapatite crystals, which will cause resistance to demineralization by acting as a reservoir of fluoride. The third thing what it does is it inhibits the enzymes such as collagenase and trypsin. So these collagenase and trypsin, of whose enzyme is this inhibiting? This is inhibiting these enzymes of the bacteria. So it has a bacteriostatic action also. Hence it stops the active microbial action. So these are the three things that actually silver diamine fluoride does. So it is a wonderful, wonderful agent when you have a patient who does not want to sit on the chair. He has an active carious lesion, he's scared of the aerator. What you can simply do is you can take silver diamine fluoride in an applicator tip, isolate the tooth and paint it over the active carious lesion. The carious lesion shall get arrested there. The only one problem is that it will leave the tooth discolored. So this you have to inform the patient first. Now, why does it leave the tooth discolored? It is because of this particular compound that is formed during the reaction between silver diamine fluoride and hydroxyapatite. So this entire reaction gives out two compounds, that is silver phosphate and silver sulfide, that gives initially a yellowish discoloration to the tooth, and as soon as it is exposed to air, it turns dark black or dark brown. So this is what has happened with this child in the first question. There was SDF application done on his tooth. The second question is, what is the material of choice for restoration after pulpotomy in primary tooth? So understand, it is a direct and very, very easy question. What they have asked, material of choice for restoration. In pulpotomy, they have not asked you any pulpotomy agent. So it is very easy. MTA is a pulpotomy agent. You place it over the root stumps, in order to fix the pulp, in order to keep the radicular pulp live. So MTA is a pulpotomy agent. Biodentine is a pulpotomy agent. Vitapex is also a pulpotomy agent, whereas GIC is the only restorative material given in here, right? So the clear answer is C, that is GIC, which is the only restorative restorative material that has been asked in the question. Now, just quickly, let us see what is pulpotomy. So, pulpotomy is when you just pull out the entire coronal pulp and you want to keep the radicular pulp live and vital. So, what you do, you remove the coronal pulp, place something over here over the stumps of the radicular pulp so that here the pulp gets fixed and the vitality of the rest of the radicular pulp is preserved. So this is called as a pulpotomy agent, which is not being asked. And then after you place such an agent, you restore the tooth. Like you restore the tooth, you fill it with a bulk filling material, which is called as a restorative material. So that has been asked, and clearly the only one restorative material in the question, in the options, was GIC. So GIC is the answer there. Here in this picture, you can see that over the pulp stumps, they've placed zinc oxide eugenol. Over that, the restorative material is zinc phosphate, and then they've placed a stainless steel crown. Then come to the third question. So the third question was, which of these agents is given to the child via the nasal route for a procedure on the dental chair? So this exact image was asked in the question. It is a direct pic from the internet, and the options given are these. So the answer here, you might get confused with nitrous oxide and oxygen, and the answer here is nitrous oxide and oxygen, because this particular thing that you can see on the nose of the child is actually coming from this setup. So this is an inhalation sedation setup in which there are two cylinders. One cylinder is of nitrous oxide, one cylinder is of oxygen, and there is this mask that is placed on the nose of the child, and we are supposed to titrate. I think back in my lecture of pharmacological management of behavior, we had covered this. So you're supposed to titer. You will flush 100% oxygen first, then eventually you will decrease oxygen by 10% and increase nitrous oxide by 10%, and so on. So this particular mask is used to deliver both nitrous oxide as well as oxygen. So the answer here is C. Then come to the fourth question, that is, which of these mixed dentition analysis does not use the width of mandibular central incisors in it? Okay, so for this you need to be knowing that how these four analyses are done. Right, so basically Moyers, though you read very commonly, Moyers you'll read here also, in ortho also. So you need to know what are these three other mixed dentition analysis. So in the Moyers analysis, basically what we do is, quickly I'll tell you, in the Moyers analysis, you will take the width, mesiodistal width of the four lower incisors of the patient, and depending on the width of the four lower incisors, there is a predictability chart that is given. So there is a predictability chart. You just take the mesiodistal width and then you go to the predictability chart, and the 75th percentile of the values that are given shall be the values that will be you can say that this will be the width of the future canine and the premolars. So in the Moyers mixed dentition, you are actually measuring the width of the lower incisors. Then comes the Tanaka-Johnson's method. Tanaka-Johnson is a formula-based method. In this, what happens? Again, you're supposed to measure the width of the lower four anteriors, that is the central lateral and the central lateral here, all the four of them. And then there is a formula here. Like what you do is you take the mesiodistal width of the four lower anteriors divided by 2. In this, if you add 10.5, then you will get the space that shall be occupied by the mandibular canine and premolars. And if in this same calculation, if you add 11, then you will get the width of the future canine and premolars of the maxillary arch. So this is a formula based method, but still in this analysis also you are measuring the mesiodistal width of the four anterior teeth, lower four anterior teeth. The third given is Hookabah's analysis. So in Hookabah's analysis, what they do is, see, this is the formula, like, you'll have an x1 divided by x2 and y1 and y2. So what you do is, you'll take the patient's cast is there, you'll take an impression, pour a cast. So in that, you will measure the width of the erupted molar, the erupted primary molar. You will measure the width on the cast, which will be called as x1, that is the width, the actual width of the primary molar. Then what you do, you take a radiograph, and on the radiograph, you measure the width of the radiographic width of the same molar. Okay, so that will be called as x2, that is the apparent width of the primary molar. That will be the apparent width. Then you will take, on the radiograph, you can also see the permanent premolar over there. So on the radiograph, you will, which is unerupted, you cannot see it in the mouth, so you don't have it in your cast. So you will take the apparent width of the unerupted premolar through the radiograph. So now when you have three values in this formula, it is very, very easy to calculate this formula. That is, y1 will be x1 multiplied by y2 divided by x2. So with this formula, you can easily find out the value of that one particular tooth, or the actual value of the premolar that is going to be erupted. So in this particular analysis, you did not measure the anterior 4 incisors. Whereas in the last option, which was Hickson's old father mixed dentition analysis, the mesiodistal width of the lower anteriors are measured, and again this one has given a predictability chart. So what question they've asked? They've asked, amongst these, which does not use the width of the mandibular central incisors? So who does not use? Hookabah's analysis does not require your mandibular central incisors. It just requires the patient's cast and a radiograph. So the answer here is C, Hookabah's analysis. I hope you're clear with all the 4 analysis. Okay. Now this question, this is again a picture image based question. Identify the appliance shown here. So there is the option says traditional space maintainer. Let us just unconsider it already. So then we have a Gerber space regainer. So generally the space regainers will have a, what do you call as, a coil over there. So there will be a coil like this here, which opens and helps in regaining space. So there is no coil present here, so this is not a space regainer. Then this can be a band and loop space maintainer, and it can definitely not be a distal shoe space maintainer. You all know distal shoe space maintainer has an arm going inside the gums in order to guide the path of the erupting first permanent molar. So such a band and loop space maintainer is generally given in case of crown and loop. See, can you see this picture? So in this space maintainer that is given in the question, this is a tube. This is called as tube, and such a space maintainer is basically called as a tube and loop space maintainer, which is a space maintainer, and it is a modification of band and loop space maintainer. Hence the answer is C, band and loop space maintainer. So this is a tube, and inside the tube goes a wire which is called as the loop. So it is called as a tube and loop, and it is very, very commonly used in case of a crown band and loop space maintainer. Okay, so if you remember, we had covered about a crown band and loop space maintainer also. So what happens, like for example, this is an E. This is a this is a E. That is the primary second molar. So in case of a primary second molar, if it is decayed, but you can still save it by pulpectomy, but the D here is grossly decayed and you need to just pull it out, you need to get it extracted. So you do the pulpectomy over here, and after pulpectomy, what you do? You place a crown. Okay, you've placed a crown, and then you know that you have to maintain this loop, maintain this space. So for this, you have to put a loop over here. But if the tooth from here erupts before this is ready for shedding, then what you'll do, when the tooth here has to erupt, you need to remove the space maintainer, but you cannot remove the entire crown. So what you do, you place a crown after the pulpectomy over here, and then over the crown you adapt a band, and on the band you solder a tube, and in the tube you place a loop, so that if the tooth starts erupting from here, you don't need to disturb this crown. You can just pull out this particular band and you are good to go. You can save your pulpectomy. Your crown is right there, and since your tooth has started erupting into the space, you can easily remove the space maintainer. So this crown, band and loop space maintainer, tube and loop space maintainer, these are all modifications of the band and loop space maintainer. Clear? Let us now come to the next question. So describe the appliance shown in the image here. So this is clearly a band and loop space maintainer. So does it have a tooth over here for functioning? No. So this becomes a non-functional because it does not have a tooth for function there. So this becomes a non-functional. Is the band fixed over here, or the patient can remove it and play with it and then place them back? So this is not removable. This is a fixed because you've put a luting cement and fixed the band around the molar. So this becomes a fixed one. Okay, and very clearly in the arch you can see this is present only on one side, not present on the other side. So this becomes unilateral. Also, there is a band present over here. There is no molar tubes. It is not bonded. So it becomes banded because it is soldered to the band. Okay, so it is non-functional, fixed, unilateral and banded. So we have it here in the option D. That is, it is unilateral. Yeah, it is unilateral. Then it is fixed. It is non-functional and it is banded. All four things that we just figured out by looking at the diagram. So the answer here very clearly is D. Let us now come to the seventh question. You had a lot of questions from Pedo. Okay, so the seventh question, I want you to just pay attention here. Success of pulpectomy in a primary tooth will depend on which of these factor combinations. Like they've given 4 factors, and a success of pulpectomy will depend upon which of these factors. Okay, so let us just go through what they've given. Pre-operative radiographic evaluation. Okay, so pre-operative radiographic evaluation for pulpectomy is very, very necessary. First, because you are dealing with a primary tooth. A primary tooth may be in a stage of physiological resorption, right? If there is less than 2/3 of the root present, there is no point of doing a pulpectomy, and you need to evaluate through a pre-operative radiograph. So pre-operative radiographic evaluation is very, very necessary. The second option here is proper mechanical debridement with correct instrumentation. So what happens? Proper mechanical debridement means that you are able to debride or pull out the entire pulp from all of the canals, like you've completely debrided the tooth, which is not possible. It is not possible to completely debride a primary tooth, because back in our lectures we've read it that a primary tooth has a lot of accessory canals. That's why you can just pull out the pulp and debride completely the one major canal that you have an access of your file into. That only you can debride. You cannot debride the entire canal. You cannot get an access to the accessory canals. Even correct instrumentation is not possible, because an IOPA is a 2D picture. Okay, you can just put it like that. You do not know that from another angle there is more resorption of the root. You might have done over instrumentation or under instrumentation from one part of the root, whereas the angle of the IOPA that you have, it might seem correct. So until and unless you have a 3D view, there is no scope of correct instrumentation, and whatever you do, you cannot completely debride mechanically a primary tooth. So this is absolutely incorrect. You cannot do this. Post-instrument restoration, yes, it is important, and the pulpectomy success depends upon it, because if the post-instrument restoration is improper, if it is improper, then that means that you've not achieved a proper seal, and that the infection can percolate inside and then again infect the particular tooth. So this is important. And amount of external root resorption, this also depends upon, this also is a great factor on which the success of pulpectomy depends. That means external root resorption, because of the physiologic root resorption which we call external, that means the physiological, yeah, the shedding, because of the shedding, the root that resorbs, that is also important, because the root resorption shall decide how much instrumentation has to be done and how much filling has to be done. So again, on this also the success of pulpectomy depends. So we have A, C and D. So here the option B is correct. That means on factors A, C and D, a success of pulpectomy is dependent. Am I clear? The 8th question says, if a good behavior in a child is encouraged and bad behavior is discouraged by positive and negative reinforcement, then this type of conditioning or procedure is called as. So we had read a lot of theories in our class, and this type of conditioning where you give positive reinforcement. So you have 4 factors in this particular theory: positive reinforcement, you have negative reinforcement, you have omission, and you have a factor called as punishment. There are a lot of students who keep asking me, giving me examples, ma'am, is this omission or is this negative reinforcement? People get confused, and I've explained it a lot of times to all of them. So, but these four factors were given by Skinner in his theory, which was called as the theory of operant conditioning. Yeah, so the answer here is operant conditioning. So wherever you see negative reinforcement, positive reinforcement, omission or punishment, that's Skinner's operant conditioning. Clear? The 9th question is, what is the amount of fluoride consumed in a whole day by an adult and a child? So the answer here is B, that is 3 to 4 mg in an adult and 0.01 to 1 mg in a child. So you just need to go through and learn this particular table. That means this is the table of daily fluoride intake. In this, you have a classification that ranges from how much daily fluoride intake is done by a child from birth to 6 months, 7 years to 12 years, 7 months to 12 months, 1 to 3 years, 4 to 8 years, 9 to 13, 14 to 18, and 19 plus, that is an full grown adult. So this is the table you need to know, and according to this, so we have 3 to 4 mg in adults, like what is given in the option, and then we have 0.01 to 1 mg in the children. Okay, so that's the answer there. The 10th question says, smart material composition is. So here the answer is ACP plus GIC. So there are materials in which they have incorporated ACP, CCC, CCP, ACP they call it. Okay, so this is CPP, ACP. That's called as casein phosphopeptide and amorphous calcium phosphate. So these things, this compound has been incorporated in GIC because this causes a reversal of demineralization and keeps the enamel intact. It increases the resistance of enamel towards demineralization, and it has been basically incorporated in luting GIC. So whenever you place luting GIC inside, say a crown, and then lute the crown with such GIC, there are lesser chances of secondary caries or demineralization of a particular tooth. Okay, rest these sodium fluoride and stannous fluoride and APF, these are all topical fluorides that can be done after GIC restoration, and there is a phenomena called as fluoride recharge. Okay, so whenever you do a GIC filling and then okay, whenever you do a GIC filling and then you apply a topical fluoride agent, what do? You recharge the fluoride in GIC. That means GIC already has a property of sustained fluoride release. You just keep recharging its ability to release fluoride. So this you can do otherwise, but this combination is a smart material that is basically done for eluting GIC. Now, this is a very simple question. Least karyogenic among the following is, so it is raw starch, obviously, because cooked starch shall go get deposited and it will convert, it will get digested and broken into sugars. Sucrose and fructose are direct sugars. So raw starch will in fact help in cleansing action, and then it will not break into sugars very easily. So raw starch is the least karyogenic. It is the least karyogenic of all of these four. Then we had a question that is, what is the amount of fluoride in Durafat? So the amount of fluoride in Durafat is basically, so what is Durafat? Durafat is a fluoride varnish. Okay, it is a fluoride varnish. So 1 ml suspension contains 50 mg sodium fluoride, equivalent to 22,600 ppm of fluoride ion, which is around 22.6 mg of fluoride in an alcoholic solution of natural raisins. So, so it is actually 22,600 ppm of fluoride, and the closest one is 22,500 ppm of fluoride. So the answer here is A. Then this was another interesting question. So see, the question here is, as per the American Academy of Pediatric Dentistry, which of these is not a type of pulpitis in primary dentition? Okay, so we are talking here about the primary dentition. See, there is an acute reversible pulpitis which occurs, like for say example, the child has fallen down and then he got hurt on one of his tooth, or there is a crack in one of his tooth, or so that will cause pulpitis, that will cause the pulp to inflame, but it will be reversible. You can use various agents, pulp capping agents, and then various anti-inflammatory drugs to reverse the inflammation of the pulp. So that will be acute reversible pulpitis, which is generally, which occurs in primary dentition. Then we have irreversible pulpitis with pulpal necrosis. Very commonly you come across, the patients will come with a nice swelling in the gums, and then they'll say that it has been decayed since a very long time, and then now there is a swelling on the gums. So that is irreversible pulpitis with pulpal necrosis. Then irreversible pulpitis without pulpal necrosis. So in this also you will see a huge carious lesion, and the patient complains of, I have pain while the food lodges, I have pain when I eat something sweet, and then when you look on the tooth, there will be a huge deep carious lesion over there. So that is the irreversible pulpitis without pulpal necrosis, because there will be vitality in the pulp inside. But there is this term called as acute irreversible pulpitis. So acute irreversible pulpitis is a condition when the pulp, when a huge carious lesion has just reached the pulp, and it has inflamed the entire pulp, and it is very, very, very painful. There is a term called as hot tooth syndrome, which generally occurs in permanent teeth in case of adults, because it is called as hot tooth, because the inflammation, the sudden inflammation is so very severe. It is so very severe that the patient has extreme sharp shooting pain. The patient complains of extreme sharp shooting pain, which is unbearable, which is radiating, and it does not subside with analgesics. It is not very easily subsidable by analgesics. That's called as hot tooth syndrome. But this case generally does not occur in primary dentition. Why? Because first is that the primary dentition, the pulp chamber is very wide. So when the caries approach the pulp chamber, there is already a very huge amount of pulp that is involved. And secondly, what happens is that there are nerve fibers. Okay, there are A delta fibers and there are C delta fibers. That are the fibers which are responsible for nerve fibers responsible for pain. Okay, so the problem is all these nerve fibers that are present in the pulp of a primary dentition are incompletely developed, and especially the A delta fibers. So A delta fibers are the ones that are responsible for sharp shooting pain. Okay, so the patient is not able to convey a sharp shooting pain, and hence he cannot relate to a situation where the pulp has just been inflamed, and he cannot convey because he is not able to sense that particular pain. So acute, when the pulp has just been inflamed, the patient does not relate. He only comes to you in case of primary dentition when the pulp has been grossly, or a lot of the pulp has been inflamed, and when the child starts experiencing dull aching type of pain. Like, he'll say it aches continuously when, whenever I eat food, whenever I don't, it just keeps aching. That is dull aching pain. That is because of the C delta fibers, and they can relate to it more. They are better developed than the A delta fibers. So an acute irreversible pulpitis is unrelatable in the primary dentition. Okay. Now the last question, direct pick from my notes if you've attended the lecture on behavior management. So we had read about fear, cry, phobias, blah, 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 everything. So in that I had told you what is a siren-like cry, and I remember telling you that it is a favorite question for the MCQ setters, that which type of cry is a siren-like cry. So siren-like cry is an obstinate cry, a cry where the child is very stubborn. He throws temper tantrums, and then he gives out loud shrill type of cry, and they are in intervals. He'll just cry very loudly so that you just leave whatever you're doing because he's very stubborn. So that is called as a siren-like cry. Okay, so siren-like cry is typical of obstinate cry. Such children are also stubborn or throw temper tantrums. So this was it. So there were these 14 questions basically from the pedo section. I think the paper, the pedo part was not very difficult. Just keep aside a couple of questions which were a little tricky, but I'm sure now you know how to solve them, and I think that it is clear to you all the explanations. If still you have any doubts, you know where to reach me. Just message on the DBMCI group, and I'll right away clear all your doubts. Keep up your preparations, keep up your hopes high. All the very, very best. Bye.